Hi, my name is Mindy Eads, and I am pleased to present to you your July continuing education. I will be presenting on Navigating Post-Acute Care, an Occupational Therapist Guide, where we will explore the following topics. Is there an advantage to the Medicare Advantage Plan? Prior authorization and appeals process, and documentation strategies to cut denials. To tell you a little about myself, I graduated from EKU in 2004 with my bachelor's degree in occupational therapy and a minor in psychology. After graduation, I worked in a variety of settings, including subacute rehab, hospital-based and freestanding, community hospital acute inpatient and outpatient, inpatient rehab facility or acute rehab, and residential and community TBI. I also did a bit of travel therapy out west and in the south. I came to UK Hospital, where I currently work, in 2016 and was a bedside therapist primarily on the trauma unit from 2016 until I assumed a new position as a post-acute care coordinator, or PACR, in March of 2024. I also obtained my prior authorization certified specialist certificate that same year. I am one of 3 PACRs and the only OT in the position, as my 2 coworkers are physical therapists. So what do I mean when I say post-acute care coordinator? In my role, I serve as a therapy liaison who gives the bedside therapist a voice, information, and support when making post-acute care discharge recommendations. With the expectations of payer sources changing drastically over the last few years, the introduction of managed plans and prior authorizations, a discharge recommendation by OTPT was no longer the way into post-acute care facilities. The number of layers and puzzle pieces that needed to fit together changed. OTPT were still making the recommendation, but without the knowledge of the patient's payer expectations, barriers to those expectations, as well as social and medical barriers. Often the recommendation by OTPT was not always a viable option when presented with the whole picture. UK Healthcare recognized this was a problem and tasked the rehab department with finding a solution or becoming part of the solution. So a pilot program was started with one experienced therapist, Kristen, who was a physical therapist, who began to look at the barriers and options patients had for post-acute care and how the patient-facing therapist recommendations lined up to those options. The pilot lasted approximately a year and was successful in decreasing length of stay and increasing patient throughput and appropriateness of discharge recommendation. This led to an expansion of Kristen's position to full-time, and 2 new PAC positions were created. With the expansion of the position, we've been able to monitor trends in denials, better understand payer expectations, and we've been able to use this information to promote to the bedside therapists how to navigate post-acute care recommendations, as well as arm the providers with support during their completion of peer-to-peers. The reason for the history behind the PAC position is important to give insight into how this position came to be and why I am qualified to present on this topic, as well as how to share the uniqueness of this role for OT. And OT has invaluable skills that can be utilized beyond the bedside. And I hope as the healthcare system continues to evolve, our skills are recognized and utilized in greater capacity. So now on to the objectives of this course. At the end of the course, participants will be able to identify documentation strategies and improvements to decrease risk of insurance denials, identify the barriers to post-acute care in relation to payer expectations, and understand the prior authorization and denial processes. Before we get too far into it, I think it's important to review some key terms. During this review portion, I task you with asking yourself the following question. Are you well versed in this language? Prior to me assuming the PAC role, I can say I was not well versed in the life cycle of a post-acute care recommendation. I knew that I would make a recommendation based on what occupational therapy needs a patient had, but I did not always understand why a patient was sometimes approved, sometimes denied, or what I could do as a clinician to increase the odds of a patient getting the level of rehab recommended. This changed when I understood the barriers that are present based on payer source, as well as the barriers we create with our own documentation. So let's review some terms now that will be helpful to improve your understanding of the process. The first of which is prior authorization. This can be required for a surgery, procedure, medication, or level of post-acute rehab, really any intervention. It must be completed prior to the intervention, or there is no guaranteed payment, meaning that the patient could be responsible for the payment in full. It's only required by managed plans. If the payer does not feel the patient requires the recommended intervention, then they will notify of an intent to deny and offer a peer-to-peer. This has a deadline that is arbitrarily set by the payer. It can be 2 hours, it can be 5 days. But if the deadline is missed, it is an automatic denial for the service or intervention, no matter why the deadline is missed. And it can typically not be resubmitted for that same intervention or level of care for 30 days. Since the peer-to-peer must be completed by a provider, if the provider misses the peer-to-peer deadline for any reason, like I said, once that deadline's missed, it's considered a denial. Even if the provider is doing direct patient care, attending to a code blue, if that deadline is missed, no matter the reason, once it expires, it is set in stone a denial. So if that peer-to-peer is upheld, meaning the denial is confirmed, then a patient can file an expedited or second level appeal, commonly referred to as a family appeal. One important note about a peer-to-peer is the outcome of the peer-to-peer does not have to be reported to the Center for Medicare Services, or CMS, which means the rate of denials is hard to track and quantify at this level. So during a family appeal, it's important that it be requested to be expedited. An expedited appeal must have a result rendered in 72 hours. If it is not asked to be expedited, then the review can take up to 30 days to render a result. The outcome of this level of appeal is reported to CSM, so there is better information on the rate and frequency of these denials. Recent reports have shown a high number of appeals are overturned at this level, which begs the question why so many were denied in the first place. If the denial is upheld at this level, then the final avenue is an external review, also called a third-party appeal or an independent review. This review is completed independent of all parties, and the decision is final and binding. This level of appeal is complicated and lengthy, and it is not typically pursued from the acute care setting in my experience. So how will we know when a prior authorization is going to be required? So all managed plans require prior authorization for interventions. So what is the advantage to them? Why do people choose them? Well, they're typically less expensive and offer perks that may be appealing to some individuals, such as free devices like blood pressure cuff, pulse oximeters, monthly grocery cards, monthly equivalent to like a health savings card that can be used on over-the-counter medications. So those with lower income or deem themselves as relatively healthy and requiring less frequent care might find the financial aspect of that appealing. They also typically include a prescription plan. The Advantage plans also waive the 3 consecutive midnight inpatient stay for admission to subacute rehab. So it's important to remember that managed plans, although they do have some perks such as cheaper, some of those monthly perks of grocery cards, etc., they require you to go to a certain network of providers and do not give the treatment team the autonomy to provide the care they deem appropriate. It must be approved by a reviewer, who is usually contracted by the insurance company, and they base it solely on the documentation they are presented with. They never actually physically treat or lay eyes on the patient they are rendering a decision for. So your Advantage plans are those plans, if you look in a patient's chart and it has something before Medicare or Medicaid. There are managed Medicaid plans as well. So Anthem, Humana, UHC, Aetna are all different types of managed Medicare plans. That's not an exhaustive list. Those are just some examples. So what is the other option then? Traditional Medicare plans, or Medicare A and B plans, are plans that do not require prior authorization and affords patients the freedom to choose their providers. They're not restricted to a certain network. This freedom comes with a higher monthly premium and does lack a prescription plan, which has to be obtained independently. This can be a concern for some individuals, especially if on a strict fixed income. The disadvantage of this plan is that a 3 consecutive inpatient hospital stay is required for admission to a subacute rehab facility. So I'm going to go into that a little bit more. So with the managed Medicare plan, a patient can arrive at the hospital and be put in observation status, meaning they don't meet the criteria for admission, but they are receiving some medical assistance or management. If you have a Medicare Advantage plan and therapy evaluates you and recommends subacute rehab, you can be admitted to subacute rehab if the insurance company approves it. Medicare A and B requires you to have 3 consecutive midnights as an inpatient before you will qualify to go to a subacute. Meaning if you're in observation for 24 hours and then you're in inpatient status for 48 hours and then you're ready to leave and you go back to observation status, you haven't met Medicare A and B's requirement for subacute rehab. This does not apply to acute or IRF rehab. So that may seem like there are some disadvantages with the higher cost, the lack of prescription plan, and the 3-day stay for subacute. But overall, the biggest advantage to this plan is that the active treatment team makes the care decisions, and in general, it's easier to get service needed due to the reimbursement rate, as well as the lack of prior authorization required. So again, with Medicare A and B or traditional plans, your active treatment team who is running your test, physically seeing you, are the ones that get to have the say in what your interventions, medications, procedures, rehab level is. So now that we know some key terms, how can we align ourselves to meet the payer expectations to reduce denials? Well, it's a moving target. Many payer sources don't have open access to their policies, even for their members. They use vague, generic wording that can be easily interpreted in a variety of ways, which makes it difficult to clearly identify the criteria. There's been recent concern that AI is being used to determine the outcome of prior authorizations. And the big issue that impacts occupational therapy is that when it comes to approving post-acute rehab, there's no clear criteria, such as what the reviewers, constitute a household or community distance, what ADL impairments they consider to prevent return to home, or generally what level of CIS they're looking for to approve rehab. as well as what level of post-acute care they will approve if they deny the initial rec of OTPT. For example, a patient has acute IRF recs, but they're denied, and the reviewer upholds denial during the peer-to-peer. But they won't say what level of care they will approve, such as subacute, which means that the authorization process will have to be restarted again once the patient has an accepting subacute rehab facility. Or sometimes the reviewer will shut down the post-acute rehab recommendations altogether and say that the patient is only appropriate for long-term care and don't have any rehab potential. So again, this can be overwhelming, frustrating, and exhausting to continue to make recommendations based on our clinical expertise, but someone who hasn't seen the patient can say they don't need what we are recommending. So when every claim comes back denied, many of us may feel like we're in a dumpster fire where we smile and say, it's fine, everything is fine. But it's not fine. And we can fight back, and we must. But how? Documentation is our best defense, and it's a skill that we as clinicians have that's often overlooked and undervalued. And the pressure to meet productivity requirements, manage burnout, navigate low staffing and increased job demands, documentation is something that seems to be the first thing to be neglected or prioritized less. Changes to documentation and use of EMR often provide clickbox information to increase efficiency, but that can be at the cost of the justification of the need for skilled services. But every single note is a line of defense. Strong records can clearly define medical necessity, reduce denials, and in turn reduce length of stay. This increases patient satisfaction and overall confidence in care. Hopefully, if clinicians are noticing reduced denials or delays in patient care, it will reduce clinician burnout and increase job satisfaction. So to summarize, without strong documentation, we can't justify to a reviewer why a patient needs the level of care that we've recommended. If our documentation doesn't support it, it's lacking, missing, or just very vague, they're likely going to deny, which will increase the patient's length of stay. If we do feel like a patient strongly meets the criteria and the facility, patient, provider team decide to go and pursue the appeal, it's going to collapse if we still don't have that supportive documentation. And this can increase patient dissatisfaction. If as a team we present to the patient we feel like they're most appropriate for this level of criteria and they meet that criteria and insurance denies and then they uphold the denial and then we have to start the process all over again and their hospitalization is extended, that can become very frustrating and disheartening to patients. And then they can also lose confidence in what our recommendations are. But with strong documentation, we can clearly justify the medical necessity for the recommended level of care. We have evidence to overturn the denial through support of the strong clinical documentation, and it's going to reduce length of stay. It's going to get patients out of the hospital and closer to home and return to their prior level of function sooner. So what can we do to improve our documentation? We want to reduce use of repeated phrases or heavy templated documentation. We want to provide clear and concise details regarding a patient's prior level of function. This is the best way to show a decline in function and need for ongoing skilled services. Identify new deficits as well as chronic deficits that may be exacerbated by the new injury or illness. And this is very important. We want to think about what is the lowest level of care the patient needs can be met at. If during an eval you think this patient could go home, but they would benefit from IRF rehab, then they're likely going to get a denial. What level of care do they need? If we think a patient could go home, the reviewer will think that also. So you want to consider and document on activity tolerance. If a patient is only tolerating 15-minute sessions and experiencing rapid fatigue, but you're recommending IRF rehab, how can it be justified that the patient can tolerate the participation requirement of IRF? This has come up a lot in peer-to-peer reviews that patients can't tolerate it based on their current documentation. So consider how you document rehab prognosis as well. If you document poor rehab prognosis, does the discharge recommendation reflect that appropriately? You also must consider expected length of recovery. If a patient has had 6 OT visits while hospitalized and has made very limited functional progress, would you anticipate they would need a longer rehab stay, such as subacute, or a shorter rehab stay, such as acute? And does that match your recommendation? In the last few slides, I mentioned acute or IRF and subacute rehab several times. Obviously, those are not the only post-acute options, but they are the most frequent post-acute facility recommendations made by OT. So it's important to know all the requirements for the post-acute levels we are recommending, especially when we consider the lowest level of care patient needs can be met at. I've highlighted some of the main differences in the levels of care here, and this may seem like common sense, but it's important to be very aware that reviewers will look at every aspect of the admitting criteria of the post-acute care recommendation and expect that the patient meets all, not just some or most of them. So for acute or IRF, medical need, which requires provider oversight at least 3 times a week and 24-hour nursing. This aspect of acute rehab is out of OT-PT hands in the sense of we don't make the diagnosis or determine how often a provider needs to see a patient. However, we can help to justify medical necessity if we notice that patients can't manage drains, they can't manage a new wound, they can't tolerate position changes due to orthostatic hypotension. They're having new onset weakness or ataxia that may require medication titration. Those are the sort of things that we can use to justify or support ongoing medical need. We also want to document tolerance to intense therapy. I know this can be tricky when we have productivity requirements and sometimes a number of patients to meet in a certain day. We don't have the time to do 3 hours of therapy with our patients today. But what it is important to do is try to maximize the time you spend with the patient. If you can justify a longer session with a patient, even if it's once or twice during their stay, and then make a clinical judgment of how that can carry over into 3 hours of therapy daily. It's important that if you report that a patient fatigues easily, that you also document that they recover easily, where it's not impacting their tolerance to their overall therapy. These are things that we commonly see as denials to acute rehab, is that they don't feel like they can meet the level of intense therapy. So it's really important to clearly state that in your note, but also provide the justification as to why you feel like they can tolerate that. The patient also needs 2 of 3 rehab disciplines to qualify for acute IRF. So OT speech, PT OT, PT speech has to be 2 of those 3 disciplines. If a patient does require 3 disciplines, I feel like that is a little bit easier to justify that they can tolerate 3 hours because the physical demands of speech therapy are less than that of OTPT. So please consider that when documenting as well. So for subacute, it's located in a skilled nursing facility, and it's short-term rehab plus nursing care. So you need either a nursing or a therapy need, and it can be one therapy need. It doesn't have to be two, like for acute rehab. The patient needs daily skilled care without the need for frequent physician oversight. So a physician is usually not on site every day at a subacute rehab. So the patients have to be much more medically stable or have a solid treatment plan that nursing can intervene on. And then, of course, we know home and outpatient services. Then there's LTAC, which does not require recommendation by therapy. It's solely based on medical need. And then you have your private pay options like assisted living, group homes, memory care, personal care, and long-term care. The important thing to remember too when looking at recommending between acute and subacute is the anticipated length of stay. Most diagnoses for acute is going to be a 7 to 10 day length of stay, and then for subacute it can be days to weeks. There's some exceptions to that typical length of stay. If you have a neurological condition, spinal cord injury, TBI, CVA are likely to get a longer stay, but your more general rehab diagnoses are likely going to be around that 7 to 10 stay. So keep that in mind when you're recommending the levels of rehab. Does a patient, are they going to progress enough even with the intensive therapy to progress in that short of a time frame for IRF, or do they need a little bit more time in the subacute? And again, you have to meet all the criteria for a level of care. So if a patient meets the medical necessity, but not the rehab necessity for acute, it will be denied, and vice versa. So it's very important to be very well versed in the admitting criteria for the different levels of care. So what are some things that you as a clinician can easily put into your practice to assist you with identifying the appropriate discharge recommendation as well as decrease denials? One thing is the more detailed the prior level of function is, the easier it is to identify and highlight any deficits that require further skilled services. And the standard prior level of function listed here, the generic statement needs assistance provides the opportunity for the insurance reviewer to interpret the amount of cyst. When compared to the improved prior level of function, where it is clear and concise, this makes it easier to identify new impairments. This may seem like an increase in documentation time, but I would argue that spending a few more minutes clarifying this information will make subsequent documentation easier, as it will clearly guide you to the patient's specific new deficits and be able to justify your treatment plan and interventions. It also takes away the reviewer's ability to assume what we mean, as their assumption will always be of benefit to them. So if we look at lower body dressing here, on the standard it says needs assist. Is that min assist, max assist? We don't know. But when you look at the improved prior level of function, they need assist with shoes and socks only. So if we're now documenting that someone requires assist with shoes, socks, underwear, pants, that is a significant change in their level of function and could warrant continued rehab. But if we're marking needs assist at baseline and just saying they need assist now, we have no way to prove that they had a decline in function. And then if you look at the other examples there, the other one I really want to highlight is the level of mobility. So a lot of times we think of people that don't go out into the community much as just household ambulators. But do they walk around their yard? Do they check their mail, which is at the end of the driveway? Do they live in a first level apartment, but they have to walk across the parking lot? So there's much more to household ambulation and community ambulation. It's not just black and white. There's a gray area there where people are kind of in between the two. So the more that we can highlight that, the more we can prove that patients have a decline, but also that they have the potential because they were doing that level prior to their admission. So some other things to consider are comorbid considerations. These alone will not reduce the risk of denial for post-acute care. However, when we're looking at medical need, if a comorbid diagnosis can be linked to a new deficit and is supported with clear documentation, then the justification for ongoing post-acute rehab is more likely to be accepted without requiring an appeal. So some examples include a patient has residual dominant right hand weakness and sensory deficits from a previous CVA. They have been able to compensate and adapt at home and are modified independent. However, they were admitted to the hospital with a bowel perforation and now have a colostomy. Their new self-care demands require skilled intervention and training to allow for a patient to adapt and compensate for the chronic impairment to return to their baseline independence. So one thing you'll notice in here is that it is highlighted that patient's dominant upper extremity. That can play a big role in creating a new baseline function when someone's dominant upper extremity is impacted. So please keep that in mind when you're looking at your documentation, especially for those patients who do have upper extremity involvement. A patient is non-weight bearing on their left lower extremity due to an acute lateral malleolus fracture, and they are a prior right AKA without prosthetic. At baseline, patient can transfer and ambulate short distances with a rolling walker. They complete self-care using only a shower chair, otherwise are independent and able to complete self-care with only the walker use. Now they must learn to transfer with use of a slide board and complete self-care from a seated position. So typically, a single limb injury is not going to be enough to get a patient into IRF rehab. But if they have the medical necessity, you can justify the therapy need by showing that they are learning an entire new set of transfer skills because their functional extremity is now impaired and they need to learn how to compensate in all aspects of mobility and self-care in order to return home. So, does a patient have a history of TBI, developmental delay, intellectual disability, or autism that requires information to be presented in a specific way for learning? Do they require repetition and frequent intervention to learn new tasks? These are all things that, if documented appropriately, can help justify getting patients a more appropriate post-acute care level of rehab. So some comorbid considerations are listed there. These are ones that I have found that with the proper documentation can help justify a higher level of rehab than the patient's current diagnosis alone may typically garner for them. So make sure you ask yourself if a patient does have these comorbid considerations that seem to be exacerbated by their current. Ask yourself these questions about the impact on their current ability. So in the next slide, I'll show you some documentation examples that were used. That were used during peer-to-peer reviews to assist with getting denials for either IRF or subacute overturned. So in my role as a PACR, we've had the opportunity to collect information on peer-to-peers, and we've tracked information on both those whose denial was overturned and those that were upheld. We've looked for trends, which I will go into the next slide. But in this slide, I'm going to review some wording that was used to successfully get denials overturned at the peer-to-peer level. And I'm going to read these to you because I do think it's very important for you to see and hear them. And then I want you to consider, do you document this way? And again, this is not to critique or say anyone's doing anything wrong in their documentation, but the more we learn about payer expectations and the more that outside entities have decision-making power in our patients, we do have to evolve in how we document and highlight deficits. And that is the purpose of this in these examples. So the first is, patient is unable to complete basic self-care tasks without cognitive and physical assistance for sequencing, initiation, and termination of task due to previous TBI. Patient benefits from increased time, repetition, and redirection, best achieved through the intensity and frequency of skilled therapy provided at an inpatient rehab facility. So this is tying in a patient's previous deficits into their current deficits and why they require that frequent skilled therapy that is only offered at IRF. Again, with all these are just excerpts. It's not the full picture of documentation, but these are some phrases that when incorporated with strong documentation showing the decline from their prior to their current level of function can increase success rates. So the second, patient is a high-functioning 24-year-old male with autism who requires specialized timeframes and learning styles to promote ability to increase independence with mobility and self-care. Due to patient's left lower extremity non-weight-bearing status, new need for assistive device, and in consideration of his cognitive needs, patient requires intense, frequent OTPT interventions to promote a reduced fall risk and return to home environment. Third, due to weight-bearing and range of motion restrictions to dominant right upper extremity, patient is now dependent with lower body dressing, including donning, doffing of orthotic required to compensate for Charcot foot, which increases risk of falls and re-injury and limits ability to safely ambulate. At baseline, patient was able to independently stand, pivot, transfer to his wheelchair using his non-affected left lower extremity. Given his left lower extremity non-weight-bearing status, resulting from bilateral malleolus fracture and right lower extremity hemiparesis and increased extensor tone, he is currently unable to transfer without substantial or moderate assistance. So in this last example here, this is bringing in some medical need that a PMR provider could address, especially with the extensor tone. They may be able to introduce medication management that can help decrease the tone. As we all know, that tone can be exacerbated by many factors, including stress, illness, new demands on the body, without necessarily a new neurological injury. So I said I would talk about some trends that we've noticed. And when I say we, I'm referring to my PAC team. These trends have been collected by the three of us, so I have to give a shout out to my coworkers, Kristen and Ashley. We've done a lot of information collection, which has been interesting, going from patient care to a more administrative side of things and looking at all the numbers that need to be seen. But it has also been very helpful, I think, in learning how, as clinicians, we do impact things maybe more so than we realize. So we're going to go through each of these points here, and I'll give you a little bit of information about why this is on here and why it needs to be considered. So the first, does a patient use an assistive device at baseline, and has it been trialed in this setting? If not, why? And this goes back to assuming that reviewers are going to understand our language. We can't assume that the reviewer is going to know that a person who's now non-weight bearing on their right upper extremity can no longer use a walker. This will need to be clearly stated. Along with that, if a patient does not have a new restriction that requires use of an assistive device for ambulation, ensure that it's being documented that the patient has been unsuccessful without the use of an assistive device and why. Balance, coordination, pain. If we're trying to get a patient back to their baseline function and there is no restriction, such as a weight-bearing limitation of why they need an assistive device, and we're using one, it's very important to document that we feel like the patient can progress past it and return to their prior level of function, as well as why we are currently using that with their mobility and self-care. I touched on this a little bit earlier, but we need to carefully interview patients during the initial eval to determine really if they are a home or community ambulator. So if someone can go out to doctor's offices 3 times a week, but tell you they mostly just hang out around the house, they're a community ambulator. Are they taking out the trash every week? That's more than just household ambulation. There's no clear definition for CSM for Medicare what a home and community ambulator is. We've never been able to get an insurance company reviewer or find consistent literature that supports what is considered home and community ambulation. So your best line of defense here is to describe what a patient's ambulation looks like. And say patients typically don't ambulate in the community except for doctor's appointments, which occur weekly. You can quantify it. It doesn't have to be black or white, home versus community. So keep that in mind to make sure that you're really given the full picture of what a patient says. And if a patient is given an option of just home or community, they're likely going to rely more on the conservative side of that. Now, as OTs, we're champions for our patient, and it's natural to want to celebrate what they can do. But why are we working with the patient? That's to address the things they can't do. We need to highlight progress, but we also need to clearly document the deficits that are still present that prevent the patient from being able to return home. So if we're saying patient is now toileting with Menasis, they're now toileting or completing grooming standing at the sink with only one seated rest break, that is awesome. They are progressing. But what they're not doing is they're still not toileting without assistive, another individual. They're still not able to complete their grooming routine without interruption. So again, we want to celebrate what the patient can do, but we really need to show what things they still need to be able to progress in order to return home. If you're saying they still need therapy, what are they still needing therapy for? And you want to make sure your notes don't look like they were mass produced. It's not uncommon for reviewers to frequently review the same facility's notes. If they feel like they are reading the same note repeatedly, it will increase risk of denial, especially if AI is being used. I will say I can't confirm that AI is being used. I can just tell you there's a lot of literature out there that is looking at the use of AI and the legality of it. I don't think it's far-fetched to think that if it's not currently being used, that it won't be in the future. And if notes are having the same phrases over and over, it's going to be really easy for a computer-generated software to pick up on that and then just immediately deny those claims or those recommendations. So make sure that you're really making your notes specific to the patient. And that doesn't mean that you can't use click boxes or smart phrases for those of you that have Epic, but it does mean that you have to support those, and that can't be the only documentation that is put in the note. So in addressing transfers, ambulation related to self-care participation, don't neglect the importance of sit to stand. Often I see a patient being denied a post-acute rehab level because they're walking too far. Again, we don't necessarily know what that means, and they're only requiring contact guard to walk that distance. However, the patient required modest assist to stand. So take this into account when looking at toileting routine, for example. If a patient can walk to the bathroom with contact guard or supervision, but they can't get up and down without moderate assistance, you really need to highlight the deficit in that transferability and how that affects the participation in the self-care task. Such as stating, despite completing hygiene and standing with contact guard assist, patient required partial moderate assistance to achieve the standing position, requiring physical assistance of another to engage in the toileting task. Another thing to consider is use of a chair follow. This is very important. If you're completing a task with a patient and they require a chair follow or have a chair behind them just in case, for PTs, it's typically walking a patient. For OTs, it's typically if they have them doing a standing task at the sink or in the shower. Why are you using it? Safety, patient anxiety, rapid fatigue, balance. These are deficits that are important to highlight. Reviewers likely won't interpret the need for chair follow or use the way a clinician will, so you must clearly document why it's required. Or trial the activity without it. Most patients aren't going to have a person who can follow them around with a chair in their home, so why are we doing it? It won't be functional in the long term for the patient. So really work on the deficits that require the chair follow. And again, if you feel strongly about using it, you need to clearly document its purpose. Don't leave it to the reviewer to interpret. Or also consider if a patient can only stand long enough to turn on the sink without the chair behind them, they're probably not ready for that task anyway. So try to work on tasks that can lead up to that, and then you can still highlight their deficit in the self-care task. So, and then lastly, I want to talk about discharge recommendation changes. It's not uncommon for patients to have a change in status, medical, cognitive, physical, that impacts their function and performance. When this happens and a change to their initial discharge recommendation is made, it's important to justify and explain what prompted the recommendation. This is true for all changes, but especially important when updating a recommendation from a lower level to a higher level of care. So if you go from home to acute or home to subacute, subacute to acute, any change from that lower level of care to a higher level of care. Anecdotally, that seems to be a flag for insurance companies and appears to increase the denial rate. So if you do make that recommendation change, which again, it's not uncommon, especially in the acute hospital setting, to require recommendation change for patients that are there. We see a lot of things that impact that. But just document why that change was made. Justify the change. Things like patient has had an additional unplanned operation requiring further medical intervention and a return to ICU. Due to this medical decline, patient is now more appropriate for subacute rehab due to inability to return home at this time. Again, we all know this stuff. It's just we have to very clearly document it now that there is reviewers who are not therapy experts making judgments about a patient they've never seen based on our notes. So in a nutshell, we can't assume that reviewers will be able to interpret deficits unless we clearly identify them. Their job's to deny services. They're working for a company to make profit. So we must provide the justification that can't be denied and leaves nothing to be interpreted. If we do leave things to be interpreted, the reviewer is always going to interpret to the benefit of the payer source, not the patient. So I know this was a lot of information in a short time frame, and with no ability to ask questions or have discussion, I would love to be able to go into more detail about denial trends and the peer-to-peer process if this is something you find interesting or have questions about. Please reach out to me. I'm happy to answer any questions or provide further information, examples, or clarify anything. So my contact information is up here. And again, feel free to reach out. I'm also going to include references on the next page if you'd like to go a little deeper on your own into researching some of the ideas and information presented here. There's a lot of social media accounts too of regarding the peer-to-peer process. So I hope that you don't feel alone in this. This is going on nationally, not just locally or statewide. My coworkers and I presented at the APTAA Combined Sections meeting in February of this year, and it was frustrating, but also a relief to know that all over the country, this is happening. So it is not just a facility problem. It's not just an OTPT problem. It is a national problem with our healthcare system that hopefully we can work to improve because our patients are the ones that are suffering, for lack of a better word, from the changes in how healthcare is managed. So as promised, here are some references. And then at the bottom, I just wanted to give a shout out and list the names of my co-presenters at CSM and the name of our presentation that we did out there, as a lot of the research and references were also utilized during that presentation. So thank you for your time and for listening, and I hope that you learned something and that you can take something away from this presentation and put into your practice. Thank you.